All right, well, welcome everybody. This is a MedChi and Lunch and Learn series event, and I'm really excited about this event. Today, we're going to be talking about physician employment trends in the U.S. and more specifically in Maryland. And we could not have a better speaker today than my good friend Matt Katz. Matt is the former executive of the Connecticut Medical Society, and he left there a few years ago to start the very successful MCK Health Strategies. And Matt now consults for physician-friendly organizations, physician groups, individual physicians, physician practices, and one of his principal clients, I'd say, is Physicians Advocate Institute, where he's done a lot of work around these types of data issues and everything. Matt has been an incredible public health and physician advocate for the last 25 or 30 years because you started just when you were 10, right?
That's exactly right. Yeah,
So
that's
anyway, and I will stop talking and turn it over to him so he can talk to you about physician employment trends in the U.S. and in Maryland. And actually, he's got some pretty exciting stuff specific to Maryland because we're apparently very different from the other states. So I'll just tease everybody a little bit, and I'll turn it over to Matt to get going.
Thank you, Gene, and thank you, MedChi, and everyone that's on today and watching later on. And Gene forgot to say that I'm 6'4" and I have a full head of hair. The camera just does weird things to me. I don't know. I am looking forward to presenting this to you today. I can tell you that Maryland has some interesting trends that we'll go over. What we're going to do to level set is I'm going to give you a little bit of where the nation is, not from a data perspective, but just from a advocacy public policy perspective, then go into the actual data from the Physicians Advocacy Institute study. Then we're going to look at Maryland specific data with some regional tie in. And then, if we have time, we're going to jump over to a second study that was done that looked even at more closely physician perceptions of their employment settings when they are employed, that was done by the Physicians Advocacy Institute and the Physicians Foundation. And I'll give a little bit of that and then leave time at the end for some Q&A. But I want to make sure people realize that during the presentation, if you want or have a question, please interject. I want this to be engaging and not, I don't want to talk to you. I want to talk with you. It is difficult for me with so many people on to see everyone raising their hand. So if Gene or anyone else has a question, or if there is a question, if someone can just, if I don't catch it, just let me know and I'll stop and answer that question. And I'm from the data perspective, I can get into the data. I can talk about the national perceptions, and what my own personal thoughts are. But I think the most important information is going to be the actual study data and what the marketplace looks like today. Does that sound good to everyone? That's good. So let me tell you about the PAI. It was created from the multi-district litigation settlements with all the national insurers back in the early 2000s. PAI advocates for physicians. I am a consultant for PAI. They have done a lot of research, including this research with Avalier Consulting and this research, the second piece with NORC out of the University of Chicago. They've also used UConn and Loyola professors to look at other aspects of care delivery and service delivery. If you have any other questions or information about what PAI does, I've given you the website and the CEO's email address, as well as mine, if you have any questions specific to me on this presentation or just in general. And as Gene said, this will be posted and available for everyone. So let's look at a little bit of the market trends. Optum, which most of you probably already know is part of United Health Group, a subsidiary of United Health Group, is the nation's largest employer today of physicians, with almost 100,000 physicians being employed. They have another 20 to 30,000 other clinicians that are employed by Optum, but they have 100,000 physicians, and they are growing. They are definitely not shrinking in their physician employment side of things. However, they are making some selective decisions about types of physician practices and types of physicians that they are employing, and they have made some adjustments. And in some parts of the country, the specialists that they used to employ are no longer employed by them, but the primary care physicians are. CVS Aetna, Another big entity, they have over 10,000 clinicians, most of those being physicians and APRNs. They have started to reduce in some places. CVS just closed their minute clinics in Utah, a group of them, though they are opening, expanding clinics with physicians, such as their Oak Street business here in Connecticut, where I am today. Evolence, that's the what used to be Anthem, they're buying ambulatory surgical centers and employing those physicians. Amazon went all in during COVID and has now gone almost all out when it comes to physician employment. Walgreens Village MD, same thing, all in, had almost 5,000 physicians. Walgreens has completely divested from Village MD, and Village MD is looking at what it's doing with its clinics as well. Walmart, again, during COVID, jumped in, but then this summer they started jumping back. Um, Private equity companies during COVID bought all these healthcare staffing companies, over 100 of them. They're starting to offload some of those, but there was a purchase during COVID. Today, 390 hospitals in this country are owned by private equity, and they own a big chunk of some other types of facilities as well. And the other thing I think that's important is because of all this transition and ownership that we're going to talk about, all the state and federal regulations are starting to change. I do want to say that private equity and health and hospital systems are not the only ones buying, employing physicians. You do have some physician groups and some physician entities that have started to increase their employment of physicians. Kaiser Permanente, Health Partners, have increased their employment of physicians during this period, during COVID and post-COVID. Intermountain Health, however, a physician group out of Idaho, has pushed back and stopped purchasing, employing physicians and physician practices. There are some federal bills that focus on private equity and employment of physicians. They probably had more legs before the election than after. Senators Warren and Markey out of Massachusetts had a bill, and then the California lawmakers had a bill as well that moved forward. But I believe the governor vetoed it in its final iteration. So none of the federal or state bills have moved that significantly recently. Physicians Advocacy Institute does have some policy, some advocacy on this. And if you look at these key principles, it's really about protecting against corporate intrusion, ensuring the patient-physician relationship, and physician autonomy. And if we have time at the end, when I talk about the NORC study that PAI did with the University of Chicago, you'll see why there's some of these policies and concerns about physician autonomy based on physicians' comments tied to their own employment situations. But these are the key principles that the Physicians Advocacy Institute has been promoting over the last year, 6 months really, since the study data came out. So let's talk now about the study itself. PAI collaborated with Avalere Health, one of the largest national companies that look at healthcare trends, to come up with this data. PAI has been working with Avalere since 2014, doing annual or semi-annual updates to the data to see what the scope is. I'm going to be reporting on data from the 2019 to 2021 study, which is really the COVID timeframe, and then post-COVID. So both of those studies, and I'll highlight what's what when we go through it, but I'm going to be reporting on the most recent two studies that Avalere Health has done on behalf of the Physicians Advocacy Institute. Here's the important information just overall. The first study in 2014 that was done, looking at data from 2012, showed that 25% of physicians were employed in non-physician owned settings. Okay, that was 25% in 2012. So 12 years ago, 13 years ago, 25%. By 2018, right before COVID, it jumped to 44% of physicians were employed by hospitals, health systems, and some other entities other than physicians. By 2022, one of the studies I'll be talking about today, 74% of physicians were employed or by hospitals, health systems, or other corporate entities. And today, or January 1st, which is when the data was most recently pulled of this year, Nearly 78% of physicians were employed by non-physicians in the healthcare market space. And these are entities that employ physicians who provide clinical care. We're not talking about doctors who are employed by a pharmaceutical company or employed by a business or corporation that doesn't provide healthcare. This is 78% of physicians who are providing healthcare outside of a few facilities that are governmental and correctional. We don't include correctional physicians and some governmental physicians, but it's at 78%. So the other thing that's important, I'm going to be presenting on physician employment and medical practice ownership. I'm going to primarily focus on physician employment because medical practice ownership is so variable based on the size of the practice. And so when you say 10 practices have become owned by some entity, it could be 10 doctors or it could be 10,000. It's harder to judge. So most of what I'm reporting on is going to be physician employment, actual numbers of trained physicians who are providing clinical care at the point of service. The database we use is the QVIA National Database for this analysis. So it's virtually all practicing physicians, clinically practicing. We pull out anyone who isn't clinically practicing. So it's not just a license; they have to be clinically practicing. As I mentioned, where we are right now, it's nearly 78% are employed by someone other than a physician. And I'm just going to go over some of you can see when we look at these graphs, the time frame. In the last, really since we left COVID.
Hey, this is Brian Organ. I stay
Yep.
there pretty frequently. Is one of the managers around? Because I have a reservation issue for next week. I'd like to.
I'm sorry, I thought that was for us.
I thought he was asking you a question too.
I'm just thinking, yeah. Okay, so national trends. 19,000 physicians, really since we left COVID, have transitioned their employment in just the last 2 years. So 19,000 across the country. It represents about 5% increase in those that are employed by non-physician settings. 16,300 specifically employed by hospitals in the last 2 years. So that's the transition in addition to what was there before. And about 3,000 physicians have become employed by corporate entities. Corporate entities are private equity firms and health insurers and other non-hospital health system or physician entities. And about 3,000 over the last 2 years. And there's a bunch of other statistics here showing the percentage. We have seen a slowing down of employment, but it has not completely stopped. And what I mean by employment in non-physician settings, non-physician owned practices. We've seen a slowing down, but it has not gone the other direction. So let's look at the national trends with a more attention to the detail of the data. Here's where we are. We left COVID at about 490,000 physicians employed in corporate or hospital settings. We're up to 503, give or take some. We did have a slight dip last year between January and July. And, some of us thought that trend would continue, but the employment trend shot back up. So there was a bit of a boomerang effect nationally. It doesn't look as much. It's more pronounced in other graphs I'll show you. Number of those that are of that total that are employed by hospitals and health systems is a little more than 350,000 across the country. And again, you can see where we were pre-COVID, January 2019, we had 283,000 physicians employed by hospitals and health systems, and now we're north of 350,000. And you can see that big jump where it was gradual leading into COVID. It jumped up significantly, though it's leveling off a bit again. Corporate entities, same thing, but we're seeing a little bit of a bend, but 92,000 pre-COVID. Now we're at about 150,000 post-COVID. So that's, a significant increase, a 33% jump since January 2019. Looking at it by percentage of those employed, again, it's about 78% of all physicians. We were at 62%. back pre-COVID. So we did see a pretty big, significant jump in a short period of time. This is the percentage of hospitals and health systems that does make them up the majority of employed docs. And you can see we went from them being the minority in 2019 to now the majority method of physician employment. And then this shows again the percentage of corporate. We were at 15% nationally in 2019. We were at 22.5%, 26, 23% in at the beginning of this year. So again, trend upwards, bending a little bit, but not significantly. And this is the owned, and you can see the same trend, but just different numbers. And again, this is looking at the practices that are owned, not the physicians who are employed. Just a different way of looking at it. Different percentages, but they track. So let's look at some regional findings, and then we'll get into the Maryland findings. So whether you like it or not, the way we broke it up was Maryland is part of the South. You're not part of the Northeast, at least in this analysis. We had to make some decisions of where to break people. And I'm sorry, because you're in the South, you also have Texas in your region. And, if talking to people in Texas, they'd like to stand out on their own, but we had to put them somewhere. And so this is how we broke things out. So when you look at the regional trends that I'm about to show you, the South is where you fall.
And Matt, we have a question in the chat. Dr. Oskin asked, how would physicians like those who are part of Privia Health designated? Are they independent or corporate owned? Similarly, what about practices who have a private equity partner, but in its own form of an investment in MCO? And essentially the way Privia works, just so you know, is that the MSO is owned by private equity. Actually, it's not anymore. It's now publicly traded. It was originally owned by private equity, but the practices are still independently owned by the individual physicians. So
if the individual practices are still owned and they're still owned and it's 50.1% or more by physicians, it's an independence, not in PE or corporate. So if the practice, not the billing entity, but the practice entity is still physician owned by majority, then it goes in the independence. If there's 10% PE, 20% PE, it's not PE in our study. It has to be 50 plus one.
Perfect. So, I think it's good base. I think you just wanted baseline info.
Yeah, that's the baseline. So to think of it that way, and we have Privia, that company in Connecticut too, and all those doctors are also independent, except a few are PE owned and part of it, the program. Those would be PE specific because they have more than 50% PE ownership.
Got it.
So let's look at the regions for a minute. And again, you're in the South for this context. This is the increase in hospital or corporate over the last 2 years, where we saw the national increase. And if you see the South for both physicians and physician practices is where the biggest bump was in ownership and employment during this last 2-year period. And if you look at then just hospital, it changes a little bit. The South is still high, but not as dominant as the Northeast that saw significantly more of an increase than the South, the Midwest, and the West. And by the way, people say, well, the Midwest and the West are low. Yes, but they saw some of their increases years ago. And so there's less physicians to become employed or practices to be owned because they saw the jumps earlier on, either pre-COVID or the early part of COVID, not post-COVID. Look at corporate entities. Look at the rise in the South of corporate entities. 115.6% increase in private equity and insurer and other entity ownership outside of hospital health systems and physicians over the last 4-year period. And then if you look at physicians, it's 60%. So the biggest locational jump was the South, followed by the Northeast. So here we look at the regional maps a bit, not the maps, excuse me, the trend lines, and you can see where that corporate and employment is coming in and comparing the South to the Midwest to the West. The South predominantly lags in hospital and health system employment, but it is high in corporate employment. And that, again, there's some state law issues. There's some corporations and where they are. But you can see the variability. So even though we presented national trends before, there is some differences by region of the country, and some of those are pretty significant. And again, I'm showing you corporate owned owned practices as well as employed physicians. Let's get to the fun part, which is Maryland. So here's Maryland for everyone. You're at 60% hospital employment and 20% other corporate and 20% independent. So you are slightly less independent than the national average. You have slightly more hospital employment than the national average, and you're a little under in the other corporate. And interestingly, which a trend we haven't seen so much in every state, but we're definitely seeing in Maryland, you're mirroring the national trend where you're seeing a slight reduction after a leveling off of other corporate. So you saw by January 21, almost a 21% employment, and you're down to 20. So it's not significant, but it is a noticeable change when it comes to the corporate side of employment. Hospital and health system, you have another interesting situation where early on in COVID, Maryland was right in the middle between where the South is and where the national numbers are. Your employment in hospitals have jumped up percentage wise around January 2021, and now you're above the national average and significantly above the South average when it comes to hospital employment in Maryland. If you look at other corporate, and again, Maryland is the blue line here, you were pretty much tracking the national trends until 2021 when you saw a reduction of that, where nationally they saw a slight increase of a bend, but your bend with the nationals kind of mirroring it, and you're mirroring the South, but the South has more corporate than Maryland does. Independent physicians, again, just to show you the other side, you saw something significant happen in January 2021 where you've seen a shift, but you're mirroring the rest of the country, though you have less independence than the South by about 5% and a few percentage more less than the national. So you can see you're mirroring those trend lines, but you did have a significant shift in those trend lines in January 2021 during COVID. Non-independent physicians, just to show you the other side of independence, 80%, you're pretty close to the national, and you can see you're trending similarly, but in January of 21, something significant happened where you saw an adjustment. So I'm going to now jump to some medical subspecialty categories using the data. In these maps and charts, the national data is a dotted orange line. And then I've broken down all the Maryland specialties by medical specialty, other physician, which is radiology, pathology, anesthesiology, pediatrics, primary care, because there is some differences there, and then surgical specialty. So your surgical areas and medical specialty areas, when it comes to hospital and corporate ownership, are significantly above the national averages. But your pediatric is significantly below, where your other physicians and your primary care really mirrors the national. You guys have more separation of specialties and employment than most states that we've analyzed. And I know it doesn't look like it, but when you've got a 30% split and differential between your pediatrics and your surgical specialties when it comes to employment, most states, other than maybe one subspecialty, and we'll get to some of those in a minute, everyone kind of mirrors that trend line and hugs around it for the state. You guys compared to the national are pretty variable when it comes to hospital or corporate employed physicians. That's one thing to note for Maryland. Then when you look at it for just hospital physicians, you can see, again, you've got a big separation between those pediatricians, the other physicians, though it's trending up, and then those medical specialties and surgical specialties being way above the national when it comes to hospital employment, significantly above it. When you look at corporate, you have these lines going everywhere. But again, in January 2021, something clearly happened in Maryland because you have this significant bump in corporate employment, then a significant loss of corporate employment. And then since that time, some are trending back up, some are still trending down when it comes to corporate employment by subspecialty. But something happened during COVID in January, between January and July of 2021, and you had this big bump up, big drop, and then some specialties have continued to drop when it comes to that corporate employment. Others have trended back up again, which again, we're not really seeing anywhere else that kind of a significant movement. I don't know what caused it, but there was definitely a 6 month to a year significant change in the marketplace. Some of those specialties are going back to the trend line that's closer to the national, others are not. So let's look at some actual specialties. So let's look at urology. So urology in Maryland is very different than the national. Your highest penetration of employment is on the corporate side, other corporate, non-health system, non-hospital, non-independent, at more than 50%. And it's pretty much leveled off. Health system has gone up a little bit, but is at 40%, pretty much leveled off. And independence got cut in half from 2019 to 2022, from 20% to 10%. But corporate is the biggest for urologists in Maryland. There are not many places where any specialty corporate has the highest percentage, but in Maryland, it's definitely corporate, and it's definitely 50%. Let's look at radiology. Now, in radiology, I included diagnostic, interventional, and also radiation oncology so that you could see more of a blend. And it's got some weird lines going on when it comes to health system and other corporate. Again, January to July of 2021, you saw an explosion of health system employment of radiologists, and you saw a loss at the other corporate level of a comparable percentage and split. So, and you now have health systems at close to 70%, and you have independence that was at 14% down to only 7% for radiologists in Maryland. Family physicians, health system is at about 50%, close to the national. Independence is at 25, and other corporate is at 25, close to the national and close to the Maryland averages. So nothing funny seems to be happening in family physicians when it comes to employment in Maryland compared to the rest of the market. And I don't mean funny, I mean something different. If you look at orthopedists, you also had something interestingly happen, but it happened a little bit before some of those other specialties. And this was in 2020, where you saw a significant drop in independence and a significant increase in other corporate, where hospital and health system has kind of been level since 2019, really hasn't changed that much. But you saw a complete shift in 2020 in July from independence to other corporate ownership. So then let's look at emergency physicians. You had a high amount of independence of ER docs back in 2019, more than 50%. That has dropped, and again, dropped significantly in 2020 into 2021. It's now 25%. So it was cut in half, the number of independent ER physicians, where the number of health system physicians went from 42% to almost 60%. So most of the employment later on is really attributed to health system and not corporate, but corporate started at 7.5% and early on had a big significant bump and has more than doubled to 16%. But the big bump in corporate happened early pre-COVID and didn't happen really during COVID. It was really the hospitals that saw the bump in employment during COVID. Let's look at one other specialty, just so you have another comparison. Dermatologists. 50% of dermatologists in Maryland remain independent. However, and health system has kind of stayed stable, 29 to 26%. However, what has changed is you in 2019 pre-COVID, it was about 6.5% of dermatologists were employed by other entities, and now it's about 24%. So that's a 300% increase in employment of dermatologists by other corporate entities, PE and insurers and other entities. But in Maryland, dermatologists are still at least 50.4% independent. I'm just going to just put up this slide that shows a little bit about the percentages and the methodology and where it came from. You can come back to this and look at it, but the IQVIA database is pretty robust, pretty comprehensive, and they go back and they spot check and they review and they verify and validate tied to National Provider ID, NPI, billing, and IDNs for corporations. So that's how they're able to weed out who's employed by who and what percentage of employment there is. I just want to show you some numbers, just raw numbers, so you can see the increase between January 2019 to January 2024. Hospital health system, you had 375,000 to 500,000. Corporate owned from 100,000 to 143,000. So even though it's slowing down at the tail end of COVID and post-COVID, it is still continuing an upward trend in general. This just shows you some other employment factors tied to the actual practices and not the physicians themselves. And this is another way of looking at it. Again, I wanted to give you some numbers to look back later, to look at percentages and see how things varied. Does anyone have any question on the data tied to employment before we get to the perceptions that doctors who are employed have on their employment situations?
This is Padmini. I have one question. So do
Yes.
you know how many physicians might have left Maryland? Do you have the total number?
The answer is yes. I do have the total numbers and I can get those to Gene. I don't have them in the presentation today, but what I can give you is the total numbers in 2019 and the total numbers in 2024. I can't break down by specialty, but I can break down by totals. So you can see if you had an increase overall, a decrease overall. I don't have the specialty specific counts, but I have the total counts, the gross counts. And I can give, and these are clinically practicing. So it's not the licensure database. It does incorporate that information in Maryland, but it's not that alone. So if I'm licensed, but I live in Connecticut and I'm not practicing in Maryland, it's not going to show me in the data I would present you with, because you're not clinically practicing there, even if you are clinically practicing in Connecticut. But the licensure database, as we all know, goes beyond that, and it's anyone who has a license, an active license. We use the licensure database to confirm that someone actually who says they're practicing somewhere and billing actually is licensed in that state, but it's not the only factor in the database, but we can get you that information. Any other questions before we go on to some of the NORC data? So as I mentioned, PAI, the Physicians Advocacy Institute, hired NORC, I forget what their acronym stands for, but it's the University of Chicago, to look at what those employed physicians were thinking and what they felt about their employment situation. After getting this data 2 years ago, right after when COVID was ending, we thought it was important to figure out, what physicians felt about their situation that had changed. So we surveyed 1,000 physicians across the country, and we asked them about their transitions. Generally, they felt, and this is a general statement, and we'll get to the percentages in a minute, that they felt there was some reduction in quality of patient care, really tied to loss of clinical autonomy. And more than half of physicians felt that their relationship with patients deviated, negatively from where it was before. And mostly that's tied to decrease in time of visits and in communication with their patients. So as we are seeing a shift from independence to employment and other situations, these are the things we have to be aware of and concerned about, is this feeling of the quality of patient care going down, loss of clinical autonomy, and issues of communication and collaboration with patients. And we're going to go into detail what some of those numbers are in a second. So I broke this down into 4 areas that the study found, and the study itself is on the PAI website. So, and there's like 50 or 60 pages of results I'm trying to summarize for you, but I broke it down into care delivery, clinical decision-making, physician practice administration, that's the hiring, firing, coding, billing, and professional satisfaction in general. And to try to look at what that means for corporate practice ownership and what are some of the successes and limitations when it comes to non-physician ownership. I'm not suggesting physician employment is bad or wrong, nor is PAI, but we have to be aware of what people are feeling when they transition to these locations of employment, and where could some of those stumbling blocks be, and how do we protect patients and physicians against some of those negative aspects of non-physician employment, physician employment by non-physicians. So care delivery, 58% of the physicians indicated that one of the top negative impacts of the ownership change tied to what they felt was clinical quality was a reduction in clinical autonomy. And nearly half said their relationship worsened with patients. So what's concerning here is someone may say, well, it's not 90%, so it's okay. But it's 58% of those surveyed that were employed, and every one of those 1,000 that we surveyed were employed. 58% of them said that there were some negative impacts, and it was tied to autonomy or loss of autonomy most significantly. And close to half said that they had a worsened relationship with their patients. And as I mentioned, it was time and communication were the biggest impact points. Clinical decision-making. So 56% said that the cost of care to patients now was driving or having some impact on their clinical decision-making. 56% again saying that the cost of the actual care to the patient is now impacting some clinical decision-making. And nearly half said that practice policies and incentives led them to adjust those clinical decisions, again, tied to cost reductions. So regardless of which one of those 2 percentages you look at, it's about half of those employed physicians are feeling some impact, incentive, and I think perverse incentive here on decision making. 37% reported moderate to low autonomy in making decisions at all. 61% said that they had a hard time referring patients outside of their ownership structure, which means outside of the hospital or health system or PE entity or health insurer that owned them. So they had a hard time making those referrals, where before the assumption is those referrals were much easier. And 70% reported their employer used incentives for physicians to see more patients. So 70% of those that were employed said that their employers were using some system to trigger more patient volume, requiring them to see more patients. On the administrative side, 2/3 of physicians said they had little or no involvement anymore in practice management policies. I guess that's good or bad, depending upon how you look at it. More than 40% of physicians said they were dissatisfied with some aspect of the administration, whether that was the management or just simple support. They responded that there was high satisfaction, however, though we expected this, with medical equipment, technology training, and the quality of technology and the policies and procedures. So new equipment, new technology, highest end EMRs, and you have the training and the staff support to use those new technologies and equipment. But interestingly, more than half physicians said they had lack of awareness of any dispute resolution process in the practice. So if someone's unsatisfied and they believe something's going on wrong, more than half of these physicians didn't even know how to deal with that dispute within their own company entity practice location. Care path and employment trends. Physicians who moved to independent practice cited that one of the main reasons was work-life balance. However, 53% of physicians surveyed said government and private payer reimbursement cuts were driving their choice to become employed versus remaining independent. So again, even though there's all these administrative and there's work-life balance issues, 53% said it was really government and private insurer reimbursement cuts, reductions, or lack of increase that was driving them to choose a different employment setting and situation. 60% of those physicians said that their current employer, that non-physician employment setting, required them to sign a non-compete agreement. And frustrations with current employment reflected that 44% of those surveyed said that they would join a union if one was available to them, which is a big sea change. Having worked almost 30 years in organized medicine, the AMA and their PRN organization years ago, 20 years ago, it was, 5% of physicians were interested and they tried to create a union. Today, it's 44% of physicians who are employed in this survey of these physicians felt that there would be something worth considering. And 74% said that there was burnout was one of the highest reasons to cause them to retire early. Just so you know, on this survey, it was 1,000 physicians. Most of the physicians surveyed were employed by hospitals and health systems, though some were employed by private equity, venture capital. Some were employed by health insurance companies. Most of those surveyed were medical specialties. A smaller percentage were surgical specialties. So with that, Gene, if it's okay, I'm going to pause and open it up for Q&A.
Can I ask another question? So do you have the same data for APPs, like advanced practice?
We do not. We only purchased and we only had them analyze. We only purchased from IQVIA physician information, and we only had Avalere analyze that physician information. We didn't incorporate. In fact, we specifically made sure it was only MD or DOs in the database in case there was any other designation. Howard, you have a question?
Yeah, Matthew, first, thank you very much for amazing data. And it's really very revealing and very consistent, I think, with what everyone sees in the, in the real life and in the marketplace. So my question is really two questions. The first question is, when I look at those curves that you showed, it really reminds me of the epi curves, the epidemic curves that we see where there's something that comes into the environment, a virus or something else, and a susceptible individuals, those who are novel and not immunized or able to ward off this whatever it is in the environment. And I'm kind of channeling Malcolm Gladwell here a bit.
Yes.
Yeah.
So are you suggesting, Howard, that maybe those that could handle independence were able to withstand stay and aren't going to change, or that some of those that transition to employment could bounce back?
Yeah, I think, well, we're seeing a plateau in the curve, and that's what you usually see with an epidemic. And you can't tell how long the plateau is going to last, of course. But all epidemics have that kind of characteristic that they peak at some point and then they go down again. And the question then on the other side of that is, who's going to be susceptible the next time there's a variation of this, and how do we immunize people or practices or providers against the next wave of whatever this is? There was a wave of this back in the 90s. It was a much shorter, I think about epidemics, that was a much shorter epidemic. It lasted 4 or 5 years, maybe.
That's because all the money went to Alabama and California and the firms that were those places, and then went belly up. Right. I think I agree with what you're saying, that there was definitely during COVID that epidemic response, and I consider it a response to the epidemic. But there was a trend starting before that, and like we started seeing that trend in 2012. It wasn't as dramatic, but it was there. And we are seeing a rebound for some specialties in some locations. Again, Maryland is very different than everywhere else because regardless of specialty and everywhere else, there's pretty much that same trend line. You guys have some specialties that are bouncing around much more significantly where it may not be a COVID or
Right.
epidemic response. It may be a market response to a PE company or an insurer who was employing a bunch of people, leaving the market, going bankrupt. You don't see in some states that I've done these presentations for, you've seen a dramatic drop in hospital employment because they've seen hospitals closed. There's been, a few dozen hospitals that have closed over the last few years, and a number of departments in hospitals. And in those states that have seen that, they've seen the hospital drop off and others come up. I don't see that in Maryland. I haven't seen the data per se. The other thing I think it's important is we didn't look at age, but I'm going to venture to guess that many of those people that are independent still are a bit older, and we're going to see those people retire. So the question is, where are those younger doctors going, and are they going into independence? And that's something we haven't looked at.
Well, and back to your point, I think that this epidemic started a long while ago, and the susceptibility was a financial susceptibility, as you pointed out, not other things probably adding to that, administrative burden, et cetera. But I think it was the financial susceptibility, and the infectious agent was people coming in who said, we can offer you some financial relief. So the question is going forward, how do we prevent this from happening again on the downside of the curve for the young providers who are entering in, who don't really see an opportunity for independent practice? So, I mean, that's really, to me, this is the situation as it exists. And certainly that, it won't be the same 10 years from now. Things always change.
I agree with you.
How will they change is the question.
So there was a doctor in Alabama when I gave a presentation in Alabama that felt that the curve in Alabama and nationally followed more what's happened with Medicare and the reductions in Medicare payment and not keeping up with inflation is why we're seeing the trend we're seeing. So just like when we surveyed those doctors, those 1,000 doctors, and we saw more than 50% saying they're where they are because of reimbursement. And by the way, I don't show it in these slides, but when online you can see in the report, it's much more pronounced in the South than anywhere else. That 53, it goes higher in the South as to why people transitioned. But it could be that the cause is not something, let's say, like COVID or EMRs, but it is the reimbursement environment, the truncation or a reduction in payment increase that we used to see, before the SGR fiasco. Right. There was a constant increase in physician reimbursement that maybe didn't keep up with inflation, but wasn't too far off. Then we saw things falling off a cliff, and then we had, macro that was going to fix everything. And for a few years, reimbursement went up a bit, but then dropped back down. And so if you look at your grids that I shared with you that'll be available through MedChi and Gene, when MACRA kind of had that regular increase and then for a few years and then saw the drop, and we've been fighting with the drop the last few years. If you look at this, that could be causing it as well. We don't know that if it's just MACRA, it could be Medicaid, but Medicaid sometimes mirrors Medicare in what they do with reimbursement, especially if they're using the RBRVS system. But I don't want to be overly negative, because in some specialties and in some areas, we're starting to see some rebound of independence in primary care, for example, or certain specialties, or like in Maryland, where dermatologists were going down, but they stayed at 50%. We're seeing a leveling off in some states with some specialties that could suggest it may be specialty specific, it may be geographically specific, but in some areas, we're not seeing the loss we were seeing before. And with retirements, that means people are coming into those specialties and into those practices. But we have not looked at the age bands, which is something we're considering, to see what's happening with those newly minted physicians and if any of them are going into independent practices. But as an aside, real quickly, I work with practices throughout the country, as small as a solo doc and as big as 700 doctors is the biggest practice I work with right now. They are all trying as independent groups to employ physicians, but they're struggling with the salaries, and in some states like New Mexico, the liability costs and being able to recruit those into private practice. It's not the lifestyle, it's the ability to pay for those doctors when the hospital or the insurer is paying 20% more, and it may be a better quality of life, at least from the young physician's perspective, because they're not taking night call or they're not having to go to 4 different practice locations.
Yeah.
But that's happening. I see, if it's okay, Howard, Rachel has a question.
Yeah, sure.
Hey, how are you?
Hi.
Thanks for the presentation. I'm family medicine for what it's worth. So I know that the pressures right now are really towards there's not going to be any increases in the reimbursements. So there's probably the next trend towards just not accepting Medicare or Medicaid at all. So does this database like take into account people who've already decided to make that choice? Or is this just looking at anyone who's accepting patients who's like a board certified?
This is looking at anyone who's clinically practicing. So
Hmm.
it doesn't matter if you're billing Medicare, billing a commercial insurer, as long as you're practicing and billing and you're not in a correctional facility or a Department of Defense facility only, you're included in this database, and everyone else is. So we tried to eliminate anyone that would be employed in situations where it's kind of very, very different or doesn't experience some of the same pressures that everyone else is experiencing. So we tried to limit it to anyone practicing in a setting where they're billing. So if you're volunteering, you're semi-retired, you wouldn't be in here. If you're a resident, you wouldn't be in here, but everyone else is in the data.
Okay. Yeah, that's interesting. It would be just really interesting to see how it changes in the next couple of years since there's so many people that are going to direct primary care.
It is whether you call it concierge or direct primary care, and I know there's a distinction and a difference, but whether you call it that or not, or you do see a lot of people transitioning there, but they're still practicing, so they would still be identified in our database as either independent, or if they're employed by a concierge company and not independently owning their practice, they'd be seen as employed. But if you're doing direct primary care, like a doctor down the street from me right now she's in the database as an independent doctor. She's still practicing. She's still seeing patients. She's got a license. She's not billing the insurer, but she's billing the patient on a monthly basis for that $150 a month, or 100, whatever is being charged. So there is, and you've got an MPI, and the other thing we capture is anyone providing a script, and you are writing scripts, and you're doing referrals, even if it's a slightly different kind of referral. So we would capture you in the database, and we do capture them now
Yeah.
in that structure.
Yeah. I mean, I have an independent practice, but I am accepting insurances and all of that at this time. But it's a decision that sort of will probably need to be made at some point, just knowing that it doesn't seem the water doesn't seem to be getting any cooler.
It is getting deeper and colder. You're absolutely right. Back to Howard's question, I didn't answer, but I want to answer is what can be done. It's advocating for a change in reimbursement, an improvement in reimbursement. Also, I think personally, changing some state and federal laws that allow physicians to engage in the healthcare space a bit differently, being able to own hospitals again, own birthing centers again. In some states, doctors can't own birthing centers. They across the country, there's a moratorium on physician-owned hospitals. There are over 300 of them in existence, and they seem to do well on quality. PAI has a study on that, but there's a limitation. So if you give physicians opportunity to increase their involvement in the healthcare delivery system and insulate some of those reimbursement pressures by owning other entities like they own ASCs, it may cause a rebound, or at least a barrier to transitioning to those other types of practices. The other thing is making sure there are laws, regulations that monitor some of this. We don't, if someone chooses to be employed, that's fine, that's great, that's their choice. But what we don't want to do is have them go into an employment such situation where politics or business dictate clinical decision making and not the physician's autonomy to make those clinical decisions on behalf of their patients in that patient physician relationship. So we've got to make sure there are guardrails because there is abuse, and our study showed there is problem there. So we've got to look at those laws that if you choose to do this, that's fine, but that employer has to live by certain rules and expectations where you can't simply say you can't refer outside of our limited network for this patient because that patient may need care that's in the community, but not in your network of tied to the employer. So I think those are the kind of things we need to look at. And if we protect, and California was trying to do some of that stuff, but it got vetoed. Some states have stronger protections. California and Texas every state has seen the trends that we shared today in general, but some states have done a better job because they limit the corporate practice of medicine or they require certain regulatory review before big practices are purchased. Those are the kind of things I think we need to look at.
Yeah, and we have a Corporate Practice of Medicine Act and we restrict it, but equity and hospitals are very good at working around that. They do a very good job with their lawyers figuring out how to drive things through it. And I thought Dr. Grant's point about the concierge direct primary care is a good one. And maybe in the data, if you can see the increase in that, because I do think that is going to be part of the next wave as we react to the epidemic that Dr. Half mentioned. I think you're going to see, and we've already seen it here anecdotally. I can tell you, I know lots of physicians have concierge or direct primary care practices. They're not even, they used to be in areas like Bethesda. Now they're everywhere. Now they're in Chestertown. They're on the Eastern Shore. They're in rural areas. So it's you can see that business model is one of the things that's happening. So
I
this is
agree.
great stuff.
I
Yeah.
go to a doc that gives you an option of direct primary care or insurance as a relationship, and my wife goes to a direct primary care family physician. And that may help the primary care doctor some. It's really hard to do some of those models as a specialist, though.
Mhm.
So what do we do? What options are available? Shared savings, some of them are good, some of them are half baked and create more problems. But what do you do for the specialist? What do you do for that neurologist? What do you do for the ophthalmologist? What do you do for the orthopedic surgeon? Very hard to do direct or concierge outside of maybe dermatology in that model as a specialist. So I think there are things to look at.
There's a bit of a math issue also. If everybody does direct primary care concierge, it leaves a much larger portion of the population without any health care, which doesn't solve our problems. It makes it worse.
Absolutely. In fact, CMS is so worried about that they're finally requiring Medicare Advantage plans to demonstrate that people can get appointments. Because in some certain areas, those insurers have cut their networks, and in other areas, you have a large amount of direct primary care. So there's no one for those MA plan members to see. I mean, so they finally came out with these requirements that kick in January of this coming year that are, well, supposedly kick in, that are supposed to dictate to these MA plans some ability of access. So it's not just geographically you have one cardiologist within 30 miles. It's now whether someone can actually see that cardiologist and get in within 10 days, because we know it takes 3 months because no one else is there. So I think that we have to be more creative in how we look at some of this than we have in the past. And because of all these different practice models, I also am very worried about some of these PE firms that are in for the short term. Like, I'm not as worried about venture capital because they want to stay in for the long term. That's how they get their return. But some of these private equity companies, it's quick turnaround. And we're seeing some of them go bankrupt. We're seeing others pull back. Just like we saw Amazon and Walmart, CVS, Walgreens, they're all pulling back. What happens to those doctors? Do we lose them, or where do they end up? And in the last 2 months, there have been over 10,000 doctors that have been publicly eliminated from their positions, which has really never happened before. But it's because of all this elimination from these big national, multinational corporations that bought these folks, employed them during COVID, and they're releasing them. So it'll be interesting to see what our data shows in 6 months where everyone landed.
Well, Matt, we gotta let a lot of these doctors get back to seeing patients now that you've really cheered them up during their break today. But I just want to thank you again for presenting today, and thank everybody for participating and asking questions. This is great stuff, and we will definitely share the information with the other folks who registered and probably got caught up with patients and couldn't be on, and with the entire MedChi. We'll put it up on the website, so it'll be available, and we'll share the slides with everybody as well.
And Gene, I'll get you the count data for 2019 to 2024 so you can see those that are clinically practicing what's changed in Maryland. I'll send
And
you
we'll
that.
share that with everybody as well, and especially with Dr. Radissing, who asked the question. So,
Absolutely.
thank you so much. Thank you, everybody.
Thank you all very much. Have a good day.